Hi, everybody. Good afternoon, and thank you for joining us for today's webinar. As I can see from the attendees today, we're reaching really a global audience from the US. Warm welcome to everybody from the US, South America, from Asia Pacific, from the Philippines, India, and Indonesia. We also have a broad reach across Europe, also participants from the Middle East and Africa. So really a broad reach today. So warm welcome to you all. First of all, my name is Monique Dalton, and I'm the EMEA Product and Marketing Segment Leader for ERCP and Hygiene Solutions at Pentex Medical, and gives me great pleasure to be the moderator for today's webinar. And before I move on to introduce our key experts and the webinar content, if you haven't already done so, could I kindly ask you all to mute your microphones, and this will ensure a smoother running of today's webinar. So as you've seen already from the event invitation and also from our flyer description, we have a really exciting topics ahead of us today. And with that in mind, it gives me great pleasure to introduce to you our key experts. So firstly, Professor Markus Neurath. He's the Director of the Department of Gastroenterology, Hepatology and Endocrinology. And he's also the Dean of Faculty of Medicine of the FAU Erlangen-Nuremberg in Germany. So warm welcome to you. And also secondly, we have Professor Timo Rath. He's the Professor of Endoscopy and also the Department Head of the Ludwig Demling Endoscopy Center, also in the same institution, the University of Erlangen in Nuremberg in Germany. So really a warm welcome to you both, and thank you very much for your key participation in today's webinar.
Hello.
Okay, and so to give you an overview of today's proceedings, after my introduction here, I will hand over to you to Professor Markus Neurath, and he will introduce to you COVID-19 and also give you a bit of a background about the disease. And then Professor Timo Rath will talk about really daily endoscopy challenges in GI endoscopy in light of the COVID-19 crisis, and also give you an indication of maybe the differences or the challenges between the recommendations and real reality. Of course, after this, we will have a Q&A session. And in an ideal world, of course, we would love to answer all of your questions with our key experts. But of course, if we don't have time, please don't worry. We will retrospectively answer all of those questions with our key experts and then post the Q&A on our LinkedIn page. So with that in mind, we hope you enjoy today's webinar, and now I would like to hand over to you to Professor Markus Neurath.
So hello also from my side. We have actually divided the presentation today in two different parts. First, I will give you an overview about the COVID-19 situation and about our current insights into pathophysiology. And this will be followed by Timo Rath's presentation on endoscopy in the context of COVID-19. So as you see from this slide, this is actually taken from Johns Hopkins University online. You see that it's still a pandemic situation. We have more than 7.5 million confirmed cases, more than 400,000 people dying because of COVID-19. And if you look at the rate of infection, it's still an ongoing pandemic situation. And this obviously is an underestimation, given the fact that in many countries we have missing possibilities for appropriate diagnosis. So what do we know about the SARS coronavirus causing COVID-19 disease? Well, this is the structure of the SARS coronavirus, and you see, obviously, it has this typical corona-like shape with this spike proteins, these S proteins covering the surface of the virus. And we know that this virus utilizes a specific receptor on the surface of human cells, and this receptor is called ACE2. This stands for angiotensin converting enzyme 2, and the virus utilizes this receptor in order to entry into host cells and to cause tissue damage. We should also be aware that there are genomic heterogeneity among the SARS-CoV-2 strains that have been isolated over the world. So you see here the phylogeny, and this demonstrates evolutionary relationship of SARS-CoV-2 over the world. You see there are marked differences, for instance, between the strains that have been isolated in Asia, those are the blue screens here, as compared to the European screens, for instance, that are indicated here by this yellowish color. So what do we know about the receptor? Where is ACE2 expressed? This is from a very recent manuscript published in Cell. They used modern single-cell sequencing technology in order to detect ACE2 on host cells, and you see quite obvious here in this upper panel that pneumocytes type 1 and type 2 do express ACE2, so the lung is obviously a target organ for SARS-CoV-2 infection. What is now the problem in the lung, and particularly in the elderly and older people? So on one hand, we have a situation that a very high concentration or expression of ACE2 is present in the nose and the throat. So this is the usual area where SARS-CoV-2 infection takes place. In older individuals, we have suppressed local immune responses, allowing the virus to expand more readily and to penetrate to lower areas of the airways, in particular to the pneumocytes in the lung. And there we have a different situation. So in older people, we have a pro-inflammatory state of the immune system that's called immunosenescence or inflammaging. So in those circumstances, inflammation takes place more readily as compared to younger people. That's why presumably older people are at a higher risk for mortality and tissue damage and death upon SARS-CoV-2 infection. However, in addition to the lung, we have a very high expression of ACE2 in the intestine, and that's obviously interesting for us as gastroenterologists. In fact, in the distal small intestine, ACE2 expression is even higher as compared to the lung, and in the small intestine, it is higher as compared to the colon. So definitely the small intestine, and to a lesser extent the colon, is a target tissue for SARS-CoV-2 infection. So in addition to lung infection in some patients, we do see intestinal infection and intestinal disease. Intestinal infection has been particularly observed in patients that are asymptomatic or who demonstrate hyposymptomatic causes of the disease. So in the lung, in the intestine, or in both areas, we have an early phase of infection where the virus enters the host cells via ACE2. So in the gut, this is intestinal epithelial cells. This is followed by a phase of acute inflammation where you have an attraction of innate and adaptive immune cells such as neutrophils or T lymphocytes. This is then followed by a chronicity of the disease or by resolution. And the outcome of this battle is determined by mediators such as cytokines. So if the anti-inflammatory cells and mediators win, we have resolution of the disease associated with antiviral immunity and suppression of hyperinflammation. And on the other hand, when the pro-inflammatory side wins, we have neutrophilia, we have a cytokine storm syndrome, and this causes increased mortality, organ failure, and respiratory failure. So the next slide provides really in vivo evidence that ACE2 is expressed in the intestine. This is from a recent paper in Gastroenterology, shown here on the lower right corner. Immunohistochemistry was performed in esophagus, stomach, duodenum, and rectum of patients, and you see here ACE2 indicated in green is not present in esophagus, but is highly expressed, for instance, in the stomach, duodenum, and rectum, so almost everywhere throughout the lower intestinal tract. Infection does not only require expression of the receptor ACE2, but also requires expression of a co-receptor called TMPRSS2. And here we have some of the data from our own group, where you see ACE2 expression in green in the terminal ileum of patients as well as in the colon. You see ACE2 is expressed on intestinal epithelial cells, and the co-receptor TMPRSS is expressed on the apical side. That's indicated here by this reddish color. So it's quite clear that in the terminal ileum you have very high expression of ACE2 and the co-receptor, and to a lesser extent in the colon. So the GI tract clearly is a key target for SARS coronavirus 2 infection. So as I told you, SARS coronavirus 2 utilizes the ACE2 receptor. So what is actually the physiological function of ACE2? And this is highlighted here on this slide. So ACE2 is involved in the angiotensin pathway. So angiotensin under normal circumstances is metabolized either via ACE into AT1R receptor driven immune responses. Those drive tissue injury and regulate pro-inflammatory immune responses. ACE2, on the other hand, signals via another receptor system and causes anti-fibrotic responses and anti-inflammation. In other words, mediates tissue protection. So SARS coronavirus, in other words, captures a normally tissue protective receptor in order to access host cells. ACE2 is not only expressed on the membrane, but can also undergo shedding, leading to the generation of soluble ACE2. It has been suggested that soluble ACE2 can act as a decoy receptor and thereby can capture SARS coronavirus 2 and thereby may suppress SARS-CoV-2 induced tissue inflammation. So let's now move back to the clinical situation. I told you it's a pandemic situation. We have in many patients mortality associated with pneumonia, with ARDS and multi-organ failure. The virus uses ACE2 and the co-receptor, and those two receptors are expressed almost everywhere throughout the GI tract, with the exception of the esophagus. In particularly, it has been shown that ACE2 is very highly expressed in the terminal ileum and in the colon. And GI symptoms, therefore, are quite frequently seen in COVID-19 patients. So it has been estimated that approximately 1/3 of our patients suffer from GI symptoms. This may involve, for instance, diarrhea and abdominal pain, but you may also see in some patients elevated liver enzymes. So how about the immune cell activation? It has been shown, and particularly in studies from China, that patients with COVID-19 infection have lower lymphocyte counts in severe cases, with a lower percentage of monocytes, eosinophils, and basophils, and they have also a decrease in T lymphocytes, CD4 T cells and CD8 T cells. On the other side, we have hyperinflammation in those patients and a cytokine storm syndrome triggered by activated immune cells, but also by activated neutrophils. And then this leads to a hyperinflammatory syndrome associated with multi-organ failure. And now, as a key question, not only for gastroenterology, but also to other disciplines in internal medicine, what is the role of immunomodulation and immunosuppression in the context of SARS-CoV-2 infection? So with regards to our IBD patients that frequently come to us in our endoscopy ward, it is important to understand whether biological and immunosuppressive agents do somehow affect the outcome of COVID-19 situation. And there may be reason for concern. So this is actually the situation in kidney transplantation. I here summarize 3 recent publications for you. A large case series with COVID-19 cases in kidney transplantation with associated immunosuppression was covered by these articles. And the authors found that transplant recipients had lower T cell counts and had a quite rapid clinical progression and much more severe outcomes as compared to the control population. So similar reports have been obtained in other solid organ transplantations. So this raised the question whether immunosuppression in general may be associated with a worse outcome in COVID-19. So fortunately, in inflammatory bowel disease, the situation seems to be different. The perhaps only exception might be corticosteroid use. So we do have some remaining concerns about corticosteroid use in IBD patients in COVID-19 situations. So this is actually an analysis recently published in The Lancet on the outcome of SARS coronavirus and MERS coronavirus infection and the use of corticosteroids. And as you can see here, steroid treatment was associated with worse outcomes, delayed viral clearance, and side effects such as psychosis, diabetes, or even necrosis in some cases, and was not beneficial in patients. In IBD patients, there are a couple of fatal outcomes that have been reported under high-dose steroid. I'll show you one example here, recently published by Matza in Gut. So you see here in this patient severe COVID-19 pneumonia by a CAT scan, and on the other hand here on endoscopy, you see clearly massive inflammation. This patient was 80 years old, received 40 milligrams prednisolone per day because of a flare, and died 10 days later. So corticosteroids are still of concern, in particular high-dose steroid use. Fortunately, the situation is different with regard to other immunosuppressive drugs. With regard to tofacitinib, it has been shown that this blocker of Janus kinases, particularly JAK1 and JAK3 blocker, is associated with an increased risk for certain viral infection, in particular zoster infections, are increasingly present in patients under tofacitinib treatment. So in the context of COVID-19, fortunately, no bad outcomes have been reported so far. In contrast, we should note that if you block Janus kinase 1 and 3, you block multiple pro-inflammatory cytokines simultaneously, and this may be in fact potentially beneficial in our patients. For instance, blockers of JAK2 have been suggested to be beneficial in the cytokine storm syndrome, and various JAK inhibitors, such as baricitinib, are currently considered for treatment of active COVID-19 infection. So due to the current unclear situation with regard to tofacitinib in IBD, treatment indication needs to be discussed in individual cases with patients with inflammatory bowel disease. How about anti-TNF therapies in inflammatory bowel disease? We know that TNF is a key factor during viral infections, and anti-TNF therapy has been associated with an increased risk of zoster infection and hepatitis B virus reactivation and fulminant causes of liver failure in patients with hepatitis B. In COVID-19, the majority of the studies did not report an increased level of TNF in severe cases. However, other publications did note an increased presence of TNF during severe cases. However, the major factor seems to be IL-6 rather than TNF from the current literature. The effects of TNF neutralization on the outcome of COVID-19 is probably quite complex, because pro and antiviral activities of TNF have been reported in the literature, and this is a brief summary of the data that have been published in the literature. It should be also noted, however, that anti-TNF therapy has been shown to be beneficial, at least in a subgroup of patients with sepsis, in particular in those patients that have high amounts of interleukin-6 in serum, and that's particularly relevant probably to the situation of patients with severe COVID-19 infection. So currently we do not have concerns with regard to anti-TNF therapy in COVID-19. Whether or not anti-TNF therapy may be even beneficial for active COVID-19 infection is currently unclear, but it remains a possibility that this therapy is in fact beneficial for our patient. How about integrin blockade in inflammatory bowel disease? How about vedolizumab? This is an approved inhibitor of alpha-4 beta-7 integrins. No publications have been made with regards to COVID-19 deterioration during vedolizumab treatment in IBD. In contrast, there is some data in the literature suggesting that this drug may be in fact potentially even beneficial in the context of viral infection. This has even stimulated last year and 2 years ago clinical trials using this antibody as a clinical therapy for patients with HIV infection. The outcome did not suggest therapeutic efficacy, but did not report any negative outcome on HIV infection. So currently we do not recommend to discontinue vedolizumab therapy in endemic areas. However, we do recommend that patients are monitored closely in areas that are severely affected by COVID-19. Lastly, let's take a look at ustekinumab, which is a blocker of two cytokines, interleukin-12 and interleukin-23. This drug is approved for treatment of Crohn's disease and ulcerative colitis. So also here in this case, fortunately, no increased signal has been shown for viral infections in general, and no signals for deterioration of active inflammation. However, we do lack large prospective studies on the outcome of ustekinumab as a potential therapy of COVID-19. So I will end with some current recommendations on the treatment of IBD in COVID-19 situations. Obviously, we recommend hygiene for our patients. If you are in an area that is severely affected by COVID-19 situation, you should try to separate area for care of patients with suspected or proven COVID-19 infection and other IBD patients. You should try to avoid elective surgery, if possible, to avoid crowding in the waiting area. And obviously, you should postpone endoscopy if this is possible from the clinical side and not an emergency situation. Lastly, I would like to summarize my key message. I wanted to show you that the SARS coronavirus 2 captures a human receptor called ACE2 on the surface of host cells. ACE2 is very highly expressed in the terminal ileum and to a lesser extent in the colon, and obviously also in the lung of patients. With regards to inflammatory bowel disease, we have some preliminary evidence that perhaps the disease frequency is even decreased in those patients as compared to the normal situation, so they do not seem to be a particular risk situation. However, individual cases, and particularly those receiving high-dose steroids, may be at risk for severe causes and need tight monitoring. And with that, I would like to summarize that cytokines play a major role. Immune cell activation is critical in COVID-19, and cytokine blockers are currently even considered for clinical therapy, for instance, tocilizumab as an anti-IL-6 receptor antibody, or secukinumab as an IL-17A blocking antibody. So it will be interesting to see whether those cytokine blockers are in fact therapeutically effective for treatment of active COVID-19 infection. So that actually concludes my presentation, and I would like to thank you to your attention. And in order to provide a smooth transition to Timo Rath's talk, I wanted to show you at least one image from endoscopy from our recent manuscript that's now in press in gastroenterology on label-free multiphoton endomicroscopy. So we think that's the future of endoscopy, not only looking at the surface, but below the surface in a label-free situation. So without any dyes, you can see here, for instance, epithelial cells, immune cells, and collagen in blue. And I think these are exciting times for endoscopy in spite of all the trouble we have in the current COVID situation. And with that, I would like to thank you again for your attention and hand over to Timo Rath.
Sorry to interrupt, Timo. We seem to have some problems with your mic. Let us just fix that, and I'll let you know when we've fixed the problem. Sorry for everyone for this. Okay, so while we fix the technical issues with Professor Rath's microphone, I just wanted to just step in quickly and just remind everybody that if you have any questions for our key experts during the webinar, you can feel free to type them into the question box or also the chat box so we can answer those during the Q&A session. Professor Rath?
I'm unmuted now,
you
right?
should be right. Fantastic. Good.
So, yeah, warm welcome to everyone out there, also from my side. Pleasure and honor for all of us to have you here. Within the coming 20 minutes or so, I'm trying to provide you some insights and challenges that we currently face during this COVID-19 pandemic. And also I'm trying to lay out a way how we can go back to more routine during these days. So as you can see from this map shows you the distribution of COVID-19 cases as of March 13th. And as you can see, Europe was really in the eye of the storm, if you wish. And it was a very wise and tremendously forward-looking approach by the European Society of Gastrointestinal Endoscopy, or ESGE, to develop a position statement. And remarkably, this position statement came right in time during the peak of the COVID crisis, at least in Europe. And the first position statement was published on online March 18th. And at the very core of this position statement is a risk stratification and patient triage algorithm. So when we look at elective procedures, we always, according to this position statement, have to balance the risk between GI-related disease morbidity or mortality on the one hand, on the other hand, the risk conferred by endoscopy and subsequent potential exposure to COVID-19. So on the basis of this, the vast majority of elective procedures were actually recommended to be postponed. The situation is completely different in urgent or emergent procedures. These are procedures that are potentially life-threatening and they need to be done. However, we need a prior risk stratification into those patients with high risk of COVID-19 infection and those with low risk of COVID-19 infection. Now, what is high and low risk of COVID-19 infection? This is very simple and very straightforward. Low risk is characterized by the presence of three features: no symptoms suggestive of COVID-19, cough, fever, shortness of breath, diarrhea, loss of smell and taste, plus no history to COVID positive individuals or suspected COVID positive individuals, plus the absence of any travel history to prevalent regions. Although, of course, it's a pandemic, so travel history these days is a little bit non-telling. And low risk is also defined as negative testing for COVID-19. On the other side, high-risk patients are defined or can be stratified by either presence of symptoms or travel history or contact with a COVID-19 positive individual. And based on this risk stratification, purely clinical, we distinguish between low-risk patients and high-risk patients. And according to this risk profile, we choose our personal protective equipment, or PPE. In low-risk patients, it's adequate to use a surgical mask, according to this position statement, and gloves. In high-risk patients, as opposed, we should use a respirator, personal protective equipment, or respirator mask, meaning N95 filtering capacity equivalent to FFP2 or FFP3 masks, and we should wear 2 pairs of gloves. Importantly, in both patients, low risk and high risk, for example, we should use waterproof disposable gowns. And talking about personal protective equipment, I don't want to lay out this in detail, but just to make you aware of, there's a clear hierarchy on how to put on and how to put off your personal protective equipment, and I highly recommend that you visit the ESGNA website. You'll find PDFs for print out, print them out, and put them in every procedure room outside of the procedure room to be able to follow those guideline recommendations. Plus, there's a lot of online learning materials. You can watch video tutorials on how to properly donning and doffing of your personal protective equipment. Now, talking about personal protective equipment, we have the position statements with clear recommendations on the other hand, and then the reality on the other hand, and also a very wise approach from the ESGE to initiate a member survey. And with a total number of respondents, more than 500, it's kind of representative. And it shows quite a dramatic reality during the peak of the COVID crisis in terms of shortage of equipment. Almost 60% of participants reported shortage of N95 or equivalent masks, FFP2, FFP3. More than 1/4 of participants reported shortage even in surgical masks. 1/3 of participants or departments or units were short on waterproof gowns or even face mask goggles. So this tells us we have the guideline recommendations, but at the peak of the crisis, with the high demand in personal protective equipment, on the other hand, shortage. And through the next slide, I'm trying to show you some methods we did to also cope with this shortness of PPE that we are also facing. So on the left-hand side, you see a FFP3 mask that we now have available. However, the reality as of mid-April in our department or whole hospital was that our materials management had an unfulfilled demand of more than 10 million face masks. So we needed to find a solution for that, and we reached out, or the hospital reached out, to a local medium-sized medical device company. It's 80 miles from here, and they produce face masks. And the beauty of these face masks is they're reusable and washable. So every employee of the hospital was handed out 2 masks for personal and permanent use, and was instructed to self-wash these masks in the evening at home or at work using 40-degree hot water plus liquid soap. Well, why liquid soap? Because as you've heard before, SARS-CoV-2 is an envelope virus, and we know from virologists that we can destroy the lipid membrane or envelope of the virus by adding detergent or liquid soap. So this was our initial approach of how to handle the shortage of not only FFP2/3 masks, but also surgical masks. Well, oh, and just anecdotally, I can show you the mask. I have it right here. I keep it for historical reasons. So it's made out of polyamide. It's very soft, and the good thing about the softness is that it kind of very well fits to a different facial anatomy. So for me, these reusable, washable face masks were really among the heroes of the COVID-19 pandemic, and I'm pretty sure the simple masks were life-saving devices. Coming now to water-resistant gowns, looking at the ESGE position statement, recommended for every procedure, high risk and low risk. Reality in our hospital, mid-April, shortage of water-resistant gowns, so we needed to find an algorithm for sensitive and resource-saving usage of water-resistant gowns only in high-risk patients. Now the problem is, with the peak of the crisis, a lot of patients that we were currently seeing were kind of high-risk individuals. So what you see here in this video is our approach. What I'm wearing there is a long-sleeve gown, not water-resistant though, but I'm topping that up with the plastic skirting and plastic sleeves. Both are water resistant. And also, as you can see, I had the face mask that I've shown you before on, and topping that off with a surgical mask, plus hairnet goggles. So these, in the early days, was our PPE in approaching high-risk patients. Coming back then to patient risk stratification and also patient triage, it's clear, I've shown you that on the very first slide, we should always perform, or we always have to perform, urgent or emergent endoscopy. That means patients with hemodynamic instability due to confirmed or suspected GI bleeding, patient presenting with obstructive jaundice, patients with ascending cholangitis, or patients with foreign body obstruction. On the other hand, the position statement clearly recommends to postpone always all procedures for screening or surveillance. And that means also postponing patients for screening presenting with high risk for esophageal, gastric, or colon cancer. This was something that, looking at the member survey, experienced virtually all endoscopy units. 99%, almost 100% of endoscopists reported that their workload was reduced due to the COVID-19 pandemic. And also, as another layer of complexity, 90% of the participants believed that the COVID-19 pandemic will affect endoscopic training, skill acquisition, and teaching, especially of trainees and young endoscopists. But this is not everything. If we look at the public health, postponing of endoscopy has quite a remarkable effect on public health. If we look at the US, we know that more than 70 million endoscopic procedures are performed per year. And if we hypothetically postpone elective endoscopies, as the guidelines recommend, for a 6-month period, that means we have a delayed diagnosis of almost 3,000 colorectal cancers, delayed diagnosis of more than 20,000 high-grade adenomas with malignant potential. Using simple math, one can then calculate that hypothetical suspension of elective endoscopy by 6 months will result in a 6.5 increase in mortality from only colorectal cancer. Going back from cancer, it's not on the slide, but in the US, we have approximately 600,000 patients suffering from liver cirrhosis. And if we also postpone surveillance in those patients, we would kind of risk an addition of 1,500 additional terminal versial bleeding. So from these slides, you can see that postponing endoscopy is necessary, of course, in terms of with respect to the COVID-19 crisis, but we should be well aware that this dramatically affects public health. So the question from here is, can we go back to routine, or at least to more routine that we're currently doing? And in the following slides, I'm showing you how we organize currently our endoscopy situation now that we are in the early recovery phase. So outpatients organization of the endoscopy suite starts 1 day prior to endoscopy. We have all side entrances of our hospital still closed. There's only one entrance how you can enter the department. And here we have an entrance check. Patients are asked for symptoms suggestive of COVID-19, fever, cough, shortness of breath, smell, taste loss, diarrhea. And they also need to fill out an additional questionnaire. Also, we assess contact history and travel history. And on the video, you see the entrance check by a member of the department entering. So only this is the entrance to the hospital. All side entrance is closed. And then you see here our entrance check, physical barrier, so you can't pass by. And here we, mainly on the basis of volunteers, staff members, students, have the entrance check. And if the patients come without a surgical or face mask, we provide them one and instruct all people entering the department, all patients entering the department to disinfect their hands. No visitors allowed. And also 1 day prior to endoscopy, we use a test and triage algorithm. That means we test every patient presenting for endoscopy, no matter whether upper or lower GI tract. And we do a RT-PCR. For outpatients, we schedule patients to arrive between 7 and 9 a.m. Patients present to a screening bay outside of the endoscopy unit. A dedicated nurse takes the nasopharyngeal swabs. Patients are then instructed to self-isolate for the next 24 hours. And in the afternoon, quite some logistics behind, we call the patients with their test results. or to be more concrete, we changed the algorithm. We only call patients with a positive test result to cancel or postpone the appointment. And those patients, those outpatients that present 1 day prior to endoscopy are scheduled for next day endoscopy, and ideally we perform that in the morning. In patients with a little bit different algorithm, patients present directly on the ward, typically at 7 a.m. We immediately take nasopharyngeal swabs, send these to the labs, and then we schedule patients for same day endoscopy, which then starts at noon. So in the morning, we have outpatients from the day before. Noon to afternoon, we try to restrict for our inpatients. All that we can only do because we have very fast RT-PCR. We use a system called Kovac from Roche. The first 96 samples are analyzed within 3 hours. All the subsequent samples are faster, and the results are for them are available in 90 minutes. But our approach is here to really have a sensitive test with more than 95% sensitivity. This is here the dedicated room, quite some logistics behind because space is limited. You need to find a room or space where you can take the swabs, and we use it, although small, but sufficient for our needs, a small room, which we exclusively use for taking the nasopharyngeal swabs from those outpatients. On the day of endoscopy, we again have the entrance check, so it's kind of double checking symptoms. This is now a patient approaching our endoscopy unit, and luckily we have our front desk has a physical barrier anyway, which is a removable glass cover. So we again check the questionnaire that the patient brings with us, and then the patient waits for the final endoscopy in our waiting area, where we pay attention to social distancing with respective signs. And this is now a procedure that we did last week. Low risk patients, so no symptoms, negative history, no contact, negative testing, and also low risk procedure. This is a patient where we performed full thickness resection due to non-lifting adenoma with high-grade dysplasia. So to me, these are really the patients that you don't want to see on a 6-month waiting list. And as you can see, all people involved still wear PPE, hairnet, goggles, surgical mask, gowns. And in terms of training, we return to allow training. So here we have a bystander watching the procedure and to learn about full thickness resection, because it's important that we also take care of education in these early recovery phase. Completely different story in high-risk patients here, also from last week. A patient from nursery home, per se, at a high risk, presenting with hemodynamic instability. So this patient was directly admitted to intensive care unit. We clearly have warning signs. Performed the endoscopy with our mobile unit on site, so on the intensive care unit. And the good thing is that we have an anti-room attached to the actual isolating box where the patient is, where we can properly put on and put off the protective equipment. And so I think the how to go back to routine is really an issue these days. As shown here, this is a very nice algorithm presented from the Australian group led by Michael Burke. As you can see from this algorithm, in emergency procedures, it's per se a life-threatening conditions. We need to perform endoscopy as soon as possible. So in these situations, no need for point-of-care testing, but you make a risk stratification based on clinical and epidemiological risk into those with high risk for COVID-19 infection, those with low risk for COVID-19 infection. And if it's low risk for COVID-19, you should perform endoscopy with enhanced precautions. Enhanced precautions meaning that you still wear a respirator mask, N95 or equivalent, but no need to isolate the patient, no need to use a negative pressure room. However, if the risk is high for COVID-19 infection, you apply maximum protection, isolate patient, ideally endoscopy in a negative pressure room if available, apart from all the other measures, respirator mask, etc. Urgent procedures, we have the possibility to further stratify the individual risk based on point of care testing. For example, if you have a patient with low clinical and low epidemiological risk, but who has a positive test result, either iNet or PCR, you still perform endoscopy, of course, perform endoscopy with maximum precautions, negative pressure room if available, isolate patients. However, on the other hand, if you have a high-risk patient from clinical and epidemiological risk factors, but in negative PCR, you're good to go with enhanced precautions. No need to isolate, no need for negative pressure. Elective procedures are more intense to book and to plan. On the basis of elective planning, planning elective procedures is still a risk stratification into low and high pre-test probability, but it's advisable, according to this position statement, to then apply in those patients with low risk serological testing, IgG, IgM levels to see whether they have been previously exposed. High risk patients on the basis of clinical and epidemiological risk factors should report to a COVID clinic first, and once cleared there, proceed to serological testing. And then you can book the appointment with 3-week delay. Why 3-week delay? Well, we know that viral shedding can occur for up to 3 weeks after seroconversion occurs. But once this is clear on the day of endoscopy or 1 day prior to endoscopy, you should apply a point of care test, RT-PCR or iNet testing. And if that is negative, it's advisable, or you can, I think, with good evidence, to proceed with standard precautions. Standard precautions meaning surgical mask is enough, no need for goggles, no need for hairnet. However, if no test is available, you should still stick with enhanced precautions, respirator masks, hairnet, goggles. And if at the day of endoscopy or 1 day prior to endoscopy has a high risk, you should by all means try to postpone or defer the endoscopy. And something very similar covered just recently by Buhayi from London has been published a couple of days early in Gut, following a similar approach. And this is just for further reading. You can find more advice on how to safely restart GI endoscopy in the area of COVID-19. So with this, thank you very much.
Thank you very much to you both, Professor Neurath and Professor Rath, for your valuable insights, experience and knowledge on GI endoscopy, both on a theoretical perspective about the virus and background, and also in daily challenges. So now I would like to start our Q&A session. Actually, we've received some questions from the market. We have around, I would say, 10 minutes for our Q&A, so I hope we get the chance to answer them all. So the first question we have received is it really needed to have a negative pressure rooms for GI endoscopy as a safety precaution during the COVID-19 pandemic?
That's a great question, and I really figured that this one will come up because it's I think it's really one of the pressing questions, and it's a masterpiece example, I think, between guideline or position statement recommendations and reality. So far, I've not met a person having a negative pressure room readily available. So I think if you don't have a negative pressure room available, you should work around that in that way that you isolate the patient and perform endoscopy on site. And this is also the approach that we currently prefer. Because a negative pressure room still requires, but this is a personal opinion, so be mindful of that. But a negative pressure room still requires that you transfer potentially or infect a COVID-19 infected patient through the hospital. So to me, it is from the logistics and preventing spread of the virus throughout the hospital, a reasonable alternative to isolate the patient, depending on the clinical situation, on intermediate care, intensive care, or normal ward, but have a dedicated COVID-19 ward then, and perform endoscopy with your mobile unit there. Because that way that you can still be sure that the virus or the patient, the potentially contagious patient, stays in the room to avoid spreading throughout the hospital.
Thank you very much. I can see a lot of questions popping up here in the box, so forgive me for looking this way on the screen. Okay, so here's another question on the same topic. Were negative pressure rooms not already recommended in bronchoscopy because of tuberculosis?
Yeah, same applies there. So unfortunately, I'm not a pneumologist, but during training, I also worked on the general ward for pneumology. So our approach here is, if it comes to suspected tuberculosis, we also have the patient, of course, isolated, and we go to the room with our mobile bronchoscopy devices rather than having it transported into our endoscopy or intensive care unit, or operating wherever you can apply negative pressure, just to prevent spreading of the virus throughout the hospital.
Okay, thank you very much. Okay, so we have another question here that's actually already been covered by your presentation, which was the protection protocol you're using currently in colonoscopies. Here's another question we have. Do we need to retest positive patients after 3 weeks? And if yes, do we then need to wait for a negative?
That's right. It's also something that, well, we have a typical scenario is also that we, for example, have patients with cholangitis whatsoever, and we have an ERCP done, but stent is then clotted, or we need stent removal or other procedures that are a couple of days apart from the initial testing. And our approach there is to make it feasible that we base it on newly developed symptoms. So if there's if your old PCR of point of care testing is 5, 7, 8 days old, and the patient had no history in between, no clinical symptoms suggestive of COVID-19, I think it's good to go with the old test from a couple of days ago. However, if there's a slight doubt, I would highly suggest repeat the testing if it is available to your unit. But hard to make general statement here. It's a case-by-case decision, I believe.
Okay, maybe this follows on quite nicely also. What is your opinions about the usefulness of serology before endoscopy? So I think some part of that you've already partially covered.
Yeah.
And can this, I think this is what the second question means, is that can we replace the PCR then before the procedure? Can this serology test replace PCR?
Well, I think serology cannot replace PCR, at least at the moment, because we still don't know whether IgG levels, which are known to be protective from disease for other diseases, but we don't know that for COVID-19 yet. So we don't know whether a patient that has a sufficient amount of IgG levels is actually protected. And until we don't have these data, I would suggest to have another test, at least in addition, PCR or INET. But we have to learn more about COVID-19 and especially the relevance of IgG levels, which we don't understand yet.
Okay, thank you. Actually, from the same participant, we have an additional question with continuing on. So with regard to the positive question. So the initial question, which you've already answered, was, Do we need to retest positive patients after 3 weeks? And if yes, do we need to wait for a negative, which you've already answered? And the follow-on from this was, what if it continues then to be positive for months?
Well, yeah. If clinical feasible, postpone the endoscopy. I mean, in the worst case scenario, you still have viral shedding, and I mean, with all the let's say in this early post-pandemic phase, at least in our region, I think we still have to be careful that we don't invite a second wave. We don't know whether it will come, but I think we still have to be very cautious not to invite the second wave ourselves. So if there's a doubt, continues to be positive, we don't know about viral shedding, I would be reluctant to perform endoscopy with standard precautions. You can perform endoscopy, but then I would use enhanced or maximum precautions.
Okay, thank you very much. So I'm just looking at the time, and I think we have just 4 minutes. So I think we've maybe finish up with one question maybe for Professor Neurath. And then unfortunately, we've run out of time. But as I mentioned to everybody, that the questions that are still coming in that we didn't have time to answer, we will answer those with our key experts retrospectively and post those onto our Pentex Medical LinkedIn page. So one more, yeah, interesting question. As long as there's no vaccine available, COVID-19 vaccine available, or coronavirus vaccine, I should say, what do you see? Would you see a COVID-19 test as mandatory for patients referred to for transplantation, for example, organ or kidney transplantation? And if so, do you see a change in this when a vaccine is available? Oh, Professor Neurath, we can't hear you.
Not sure.
Yes,
Do you
we
hear
can
me
hear you
now?
now. Great. Yes, we
Okay.
can.
So I think it's an interesting question. Obviously, you will have to do a COVID-19 testing in organ transplant patients. There's no question. I think it's one of the worst situations you can imagine to do a transplant in a patient with an active COVID-19 situation. Because if you then subsequently, after surgery, have a triple immunosuppression, then it's quite likely that you will have a severe and bad outcome with high mortality. So I think it's quite clear at this point that you have to do this in patients undergoing organ transplantation. Obviously, it's quite likely that the antibody testing sooner or later will replace this type of testing, and we will screen for patients having a protective titer as soon as antibody test kits with high sensitivity and specificity are broadly available. And of course, vaccination will completely change the game. I think at that stage, vaccination will be mandatory before organ transplantation.
Okay, thank you very much. And yeah, I would just like to, I think I just go on to the next slide here, just to let you all know, first of all, thank you very much to our key experts for your in-depth knowledge, again, your insights into the virus and also experience into current challenges in GI endoscopy. And also what's really relevant, as we've seen that the recommendations maybe differ, especially we have a very broad audience, very wide audience here today, and we know that each market is very different. So I think the insights into how to manage situations in reality as compared to the recommendations was very valuable. And so thank you very much. We've already received some comments here to say thank you very much for your content and for today. And we would also like to present to our participants that we have one other webinar coming up. And what we're doing now, as we've seen the market situations evolving at the moment, and the COVID-19 situation is, of course, critical still in some markets, but what we're seeing is a management and containment of the virus and of the disease transmission. So we're moving into our next webinar as a bridge really between COVID-19 and with more of a focus on hygiene. And where the topic here, as you can see, is has COVID-19 finally improved the focus of the importance of hygiene and infection control in endoscopy. And we have three key experts, Professor Cesara Hassan from Italy, Ulrike Beilenhoff from Germany, and also Paul Cesar from Germany. So again, another very interesting topic, and we very much welcome you to register. We've put the registration link here in the chat box, but of course, after this webinar, you will also find the registration link on our LinkedIn page. So with that in mind, again, thank you both to Professor Neurath and Professor Rath for your time and experience and knowledge. And also, I would like to extend the thanks to all of you, our participants, our key clinicians and health workers in the industry, and for your unlimited support to support all of us in the global community, not just necessarily in the COVID-19 pandemic, but in your daily jobs. So we thank you very much. And yeah, we look forward to seeing you the next webinar, and have a lovely day or evening wherever you are in the world. Thank you very much.
Thank you.